Working? Sí. Okay, our next speaker is Maite Coiras. She's a researcher at the AIDS Immunopathology Unit at the Instituto de Salud Carlos III. She studies mechanisms of latency and stability and reactivation of viral reservoirs. She's going to give the talk in English just for everybody to understand, and thank you.
Thank you. I would like to talk about a research line that we have been doing for some time now in the lab in collaboration with the Hospital Clinic in Barcelona and the Hospital Puerta de Hierro in Madrid. And it is about the possibility of using SAMSD1 as a therapeutic target against HIV-1 infection. SAMSD1 is triphosphohydrolase that is able to interfere with HIV-1 replication, mostly because it is able to decrease the TNTP pool, and then the HIV-1 is not able to produce efficiently a reverse transcription. And this is only valid for the case of the HIV-1, because in the case of the HIV-2, it's able to synthesize VPX, and VPX is able to degrade SAMSD1, and then when it is degraded, the cell can be infected. In case of HIV-1, it doesn't work because it doesn't encode for VPX. However, SAMSD1 is also HIV-1 is able to overcome SAMSD1 restriction, mostly because some SAMSD1 function is modulated by cell cycle. Therefore, when the CD4 T cells at our resting state, we have a SAMSD1 that is active because it is not phosphorylated. But once that the cell cycle progresses and the T cell enters an activation state, then there is the formation of different cyclins and CDKs that are able to phosphorylize SAMSD1 at a specific residue, threonine 592, and then it becomes inactive. And at this point, the T cell enters a cycle, it gets activated, and then HIV-1 can efficiently produce infection. And this is mostly because the TNTP pool is increased, and then the reverse transcription is efficiently produced, and after that, the provirus is integrated. So there are different types of activation that can occur in a CD4 T cell and that can modulate SAMSD1 function. And well, the most important, of course, is the TCR activation, because at this point, a full viral replication can occur because the deactivation of SAMSD1. But there are also other cytokines that can be involved that are homeostatic cytokines that are not really related with a proliferation of the CD4 T cells, or maybe only homeostatic proliferation, but that they are nonetheless able to produce a phosphorylation of SAMSD1 and then inactivate it. And they are mostly IL-2 and IL-7. So what really happened in people who is acutely infected with HIV-1 is that SAMSD1 is being interfered because of this massive activation of the CD4 T cells, and then this leads to the formation of the reservoir and the T cell destruction, characteristic of the early stages of the infection. So we have been analyzing what are the most important stimulus that can deactivate SAMSD1, and we found that, for example, PHA-L2, that is a classic form of activation of the T cells, is able to produce the SAM phosphorylation early at 2-3 days, and at this point, then the T cells can be fully infected. In the case of the homoclassical activation, like CD3 and CD28, in the absence of IL-2, we see a peak of activation of SAMSD1 that it decreases rapidly and disappears. What happened with the case of the homeostatic cytokines like IL-2 is that they are able to produce a sustained phosphorylation of SAMSD1. Therefore, if we treat the cells with CD3, CD28, and IL-2, we produce a rapid phosphorylation of SAMSD1 that is sustained and maintained for a long time. This also happens in the case of the IL-7 treatment. So this is very clear that the activation of the CD4 T cells is essential for the HIV infection, and at this point we have to search for which is the most important kinase for this activation. So at this point, we have LCK, that is one kinase that is essential for the TCR-mediated T-cell activation. And this kinase, when it's activated, it produces the phosphorylation of a variety of kinases that, for example, PKC theta is very important, and it is essential for the kinase activation and associated cascades of activation that ends in the activation of several transcription factors like NF-kappa B, NF-AT, and AP1 that are not only essential for the T-cell activation and proliferation, but also for HEV1 replication. LCK is also activated by phosphorylation, and this phosphorylation in the tyrosine 392 is very important for the activation of the LCK. Therefore, what we saw is that HEV1 infection is able to increase the phosphorylation of LCK at this residue. We have here the infection of Jurkat cells with an X4 strain of HEV1, and we observe that when the cells are infected, and we know it because we stain them with an antibody against that, we observe that in these cells, the LCK phosphorylation was active, and it was increasing as long as the infection progresses. Therefore, the LCK activation is very essential for HEV1 replication. At this point, we search for some inhibitors specific of this tyrosine kinase that were used in clinic for treating chronic myeloid leukemia. This cancer is due to the formation of a break in two chromosomes, chromosome 9 and chromosome 22, that form a new chromosome that is called Philadelphia chromosome, in which there is a new kinase that is constitutively activated, and it is called BCR-ABL. So some tyrosine kinase inhibitors were developed in order to interfere with the activity of this constitutively activated BCR-ABL kinase, and these are the most important ones that are currently used in clinic, and we have been searching for some antiviral activity with these tyrosine kinase inhibitors. The first one that was developed and that was introduced in clinical practice is imatinib, but because some resistance due to some punctual mutation in the kinase domain, a second generation tyrosine kinase inhibitors were also produced, like nilotinib, nasatinib, and bosutinib, and there is also another third generation tyrosine kinase inhibitor, that the most important one is ponatinib. They are very similar, but they have something is common is that they are all targeting BCR-ABL kinase, but they are also being to target another kinases of their serif family, like LCK, and dasatinib is a one with a wide range of action that is different to the other tyrosine kinase inhibitors too, because it is able to bind to the active conformation of the ABL kinase. So we tested for in vitro what happened with these tyrosine kinase inhibitors when cells were infected with HEV1 replication, and we observed that all of them were able to interfere with HEV1 replication, with the exception of bosutinib that was very toxic in vitro. And we also determined the effect of another tyrosine kinase inhibitors that are not in clinic but are in clinical trials. So we observed that dasatinib and ponatinib were the most potent inhibitor for HEV1 replication at a nanomolar concentration. So, because these tyrosine kinase inhibitors could be related with interference with SAMAZ1 phosphorylation, and this could be the main mechanism to interfere with HEV1 replication, we tested by Western blot what was the effect that they were producing in SAMAZ1 phosphorylation. And when PBLs were treated with PHAL2 for 48 hours, we observed that only dasatinib was able to interfere with SAMAZ1 phosphorylation. But when we treat CD40 cells with IL-7, we observed that dasatinib, imatinib, and nilotinib were the ones able to interfere with SAMAZ1 phosphorylation. Dasatinib was the more potent one. In fact, it was effective to interfere with SAMAZ1 phosphorylation even at a lower concentration than the one that is used in vivo. So what we do next was obtained PBLs from patients that were affected with this chronic myeloid leukemia and that were on chronic treatment with tyrosine kinase inhibitors, and our colleagues from Hospital Clinic and Hospital Puerta Hierro collect some blood from these patients, and we analyzed the PBMCs from all these patients that were all negative for HU1 infection. They were all healthy in their condition with hematological remission, and they were all in a chronic stage. The treatment, the median year for the treatment with these tyrosine kinase inhibitors was longer than 2 years, and they had no immune deficiency. So, first of all, we isolated the PBMCs from these CML patients on chronic treatment, and we treat these cells with CD3, CD28IL2 for 48 hours. Then we infected, and after 5 days of infection, we analyzed the proviral integration and the presence of viral proteins, and we observed that all of them, with exception of imatinib, were able to interfere with the integration of the provirus and with the synthesis of viral proteins, again with the exception of imatinib. When we analyze after 5 hours of infection the state of the retroviral transcription, we observe that all of them, in this case except loftinib, were able to interfere with both early and late revert transcription. After that, we also analyzed what was the effect that this treatment in these patients producing the phosphorylation of SAM-1, and then PBMCs were isolated and treated with PHA-IL2 for 5 days, and we tested the phosphorylation in PBMCs first, and we observed that in all of them, with the exception of imatinib, all of them they have a poor response to the phosphorylation of SAM, and when CD40 cells specifically were analyzed here, we also again observed that the most important or the most potent one for decrease the phosphorylation of SAM were all except imatinib, that was the less potent. And because CD8 T cells, they also express LCK, and they're very important for the control of the infection during the acute infection, we were worried about the possibility of the inactivation of the CD8 at this point. So we put in the PBMCs activated. They were treated with peptides against peptide of cytomegalovirus, Epstein-Barr, and influenza, and PHA was used as a positive control, and we observed no significant differences between the ability of the PBMCs from these patients to respond to any of these peptides or to the PHA treatment. And we also analyzed the effect of these tyrosine kinase inhibitors on the SRC kinase activity, because LCK belongs to this family, and then the PBMCs from these patients were treated with CD3, CD28, and IL2 for 3 days, and then we observed the kinase activity. We observed that these were the most potent that were able to interfere with SRC kinase assay that was directed against LCK and other kinases of the same family, and the less potent was imatinib, and in this case ponatinib. We also observed this interference with efficacy theta activation in these cells, and we observed that again dasatinib and at this point bosutinib were the most potent one to interfere with this kinase activity. We also wanted to determine if these cells were able to respond to proliferation and the formation of proliferation foci, and this was analyzed by bright field microscopy. And here we observed that imatinib and nilotinib were not so able to interfere with the proliferation of the cell, but dasatinib and ponatinib was very efficient, and no activation was observed in response to this stimuli. Finally, we wanted to determine if there was some activity of these tyrosine kinase inhibitors in the kappa B-dependent transcription, because it's essential for the replication of the provirus. And then we transfected, in this case, Jurkat cells, because this is a very difficult experiment to perform PBLs, although we are persevering in it. We transfected them with a luciferase expression vector under the control of the LTR promoter of HEV1 or 3 consensus sites kappa B. And we observed that only bosutinib and ponatinib were able to interfere with the transcription, but no imatinib, nilotinib, or dasatinib were able to produce any effect at this point. So the conclusion about this work is the PBMCs from these patients that are on chronic treatment with the tyrosine kinase inhibitors were resistant to some phosphorylation upon activation with PHIL2, and the PBMCs from these patients were refractory to HEV1 retranscription and consequently to proviral integration. Dasatinib was the tyrosine kinase inhibitor that was more potent against HEV1 replication, and that was observed both in vitro and in ex vivo. And we think that preserving SAMAZ1 antiviral function could be able to reduce the reservoir size during acute infection with HEV1, and this could be mostly performed with dasatinib that was the one that showed more potency at this level. So the dasatinib would be able to perform 2 different activities at this point. So at one point, it will be able to preserve the antiviral function of the innate factor SAMAZ1 because it won't be phosphorylated. And the second thing is that it will interfere with LCK phosphorylation. Therefore, it will interfere with T cell activation and proliferation. Therefore, in the case of the absence of dasatinib, this would be a permissive CD4 T cells because SAMAZ1 would be phosphorylation, the TNTP pool will increase, and then the retranscription will occur and the proviral integration. In the presence of dasatinib or the other tyrosine kinase inhibitors, no activation will be produced, and then there will not be phosphorylation of SAMAD1. The cell cycle will not progress, the TNTP will remain at a low level, and there will not be no retranscription and no integration of the provirus. This work was performed in the AIDS immunopathology unit that is directed by Dr. Alcami, and these are the most important collaborators, Mercedes Bermejo and Elena Mateos, of course, our colleagues in the hospital clinic and the hematologists in Hospital Puerta de Hierro, Bristol Mayer, who provided us with dasatinib, and of course the patients who contributed to this work. Thank you.
Thank you, Maite. Any questions?
En castellano, porque en inglés me voy a liar un poco. Maite, o sea, básicamente tomabais células de pacientes que estaban siendo tratados con dasatinib por leucemia, mieloide crónica, y hacíais los experimentos in vitro de infección, fosforilación. Asumíais, por tanto, que esas células, cuando estaban in vitro, no estaban expuestas al dasatinib, ¿cierto? Expuestas al dasatinib. No estaban.
No.
¿Y cuál era entonces la razón? ¿Pensabais que estaban, aunque estuviesen fuera del organismo, el efecto del dasatinib in vivo se prolongaría ex vivo?
Claro, porque estas células son de pacientes que están tratados in vivo. Entonces, una vez que están fuera del organismo, nosotros las cultivábamos, las teníamos como unos 7-10 días en cultivo y nunca añadíamos más inhibidores al cultivo. Pero la concentración de dasatinib o la permanencia de dasatinib dentro de la célula es muy estable. De hecho, los experimentos que hacemos in vitro solamente añadimos dasatinib al principio. Bueno, dasatinib y los demás inhibidores. Pensamos que algunos de ellos pueden tener menos vida media en cultivo, pero en el caso de dasatinib tiene una larga vida media en cultivo, por lo menos 10-12 días permanece, y las células de los pacientes eran tal cual.
Expuestos a dasatinib daban los resultados.
Exactamente. E incluso a la misma concentración la utilizábamos in vitro, la misma que alcanzaría en vivo.
Just to follow up on that as well. So is it then correct that if you take cells from an antiretrovirally treated person and you try to add the drug in vitro, that you will not see that you basically can't really measure it in vitro? Is that correct? Because if you block the kinase, you will block the interleukin-2 mediated expansion that you need in order to see the reactivation virus to come out. So by blocking the proliferation, you're also blocking the sensitivity to see the effect on the latent reservoir. So it's almost like a circular argument. Is that correct? Or am I not understanding it? Because I'm trying to determine if you add this drug in vitro to cells from a patient that is suppressed, you may not be able to measure the effect on the latent reservoir. Is that correct?
But you mean in the absence of further activation?
Well, the things that you need activation in order to get the
Yes.
virus out. So the system itself may not be adequate, so you need some other system to test it.
If you take cells from an infected patient and you culture them in the presence of a stimulating activation, for example, PHAL2, you should be able to recover the proviral reactivation. But in the presence of these inhibitors, you won't see anything. In fact,
But that would be because the cells are not proliferating,
of course,
not because the virus is gone.
no, it would be because two things. The cell would not be proliferation,
Right.
proliferating, and then the SAMSD1 will be interfering not with the reactivation of the provirus, but with the reinfection of the cells.
But the virus can't get out, is what I'm saying. So
at
that
this
if you're
point-
then, if that's correct, if you treat a person, then you're basically keeping it static. You're not removing the virus, you're just keeping it silent.
But you only can reactivate the virus if the cell is activated. If you have enough transcription factors in order to reactivate this provirus. But in the presence of these substance, for example, the dasatinib is not active in transcription, but it is active in the reactivation of the proliferation. If you don't have proliferation, then you will not have
That's right.
reactivation of the
That's right.
provirus.
So the virus. So that's fine. My second question is: have you looked at combining this with the IL-15 superagonist? Because there's a discussion about targeting the latent reservoir by IL-15 in relation to its immunomodulatory. Now, one side says that's going to be a problem because the constitutive proliferation is going to expand the latent reservoir, while the other says, no, it's going to be an immunomodulator for antiviral control. And I would wonder whether if you add this strategy together with the IL-15, you may limit the expansion that you would otherwise expect just by the proliferation alone, making the immunomodulatory side perhaps a little bit more effective. But
I don't know. We have performed some experiments with IL-15, and it has a similar behavior than IL-7. So I think that if dasatinib is able to interfere with the phosphorylation of SAM in the presence of IL-7, it should be working with IL-15. I don't know, but maybe the effect will be the same. And this is why we think that these type of inhibitors could also be used in chronically infected patients.
Wouldn't you actually induce immunodeficiency by this treatment because T cells that have active SAMHD1 and low DNTP cannot do much?
We thought the same, but the hematologist told us that these inhibitors are not causing immune deficiency. In fact, these patients, it is incredible, we think too, because the cells are absolutely in energy, but they are all only acting on CD4 T cells and maybe CD8, because the CD8 you saw by a spot that they are working fine, but they have no effect on dasatinib, for example, is able to interfere with the granulocytes. In fact, it eliminates them. From the flow cytometry analysis, we saw no granulocytes in the PDMCs. But these patients had no more infection of viral origin or fungi or nothing. They have no immunodeficiency, and they are perfectly fine. And they used to recover from the leukemia.
So I agree with your comment. So if you try to activate cells in the presence of these compounds, you won't activate the cell, right? So maybe this could be a treatment suite for, not for purging HIV reservoir, but for preventing the establishment of HIV reservoir in acute infection. What do you think?
We have antiretroviral therapy. I mean, we already have antiretrovirals for that.
This could be a complement on antiretroviral therapy in acute infection.
Yes, in fact, these compounds should be used as adjuvant of the antiretroviral therapy, but we think that they could be better in order to avoid the formation of the reservoir if they are used in a very early stage of the infection.
So if there are no more questions, I think that's the end of the session. I'd like to thank the speakers once again, and thank you everyone for being here.